Let's move on to the next segment now. In the previous segment, we discussed the pediatric assessment triangle, as well as some pearls and pitfalls for overall pediatric patient care. In this segment, we're going to discuss the pediatric crashing patient protocol for medical patients. Here you see the protocol overall. I ask you if you're using a mobile device or a phone, or if you have a second monitor screen for your computer to pull the protocol up. That way we can follow along together through a guided tour. At the top of the page, you'll notice it's identical for the pediatric as well as the adult patients. So if we recognize a general impression of a patient in extremis, we're not going to move that patient to the ambulance at that point. Don't forget to request additional resources as you need to. And then we're going to obtain a full set of vital signs, including blood pressure, heart rate, SpO2, EKG. Don't forget about a temp, as many pediatric patients may be febrile. And then also get a glucose. Don't forget about that, and especially in your younger kids. Then we're going to initiate waveform capnography, especially if the patient will tolerate it. Then we're going to attempt to get 360-degree access. 360-degree access doesn't mean, though, that if the patient's calm and cooperative in the patient's arms, to pluck them out of there, start them crying, and get them agitated and obscure our assessment. So again, if they're comfortable in the parent's arms, leave them there. But at the same time, we do need to lay hands on that child as quickly as possible. Let's talk about our goals now. So our goals for our crashing patient medical, for respiratory, it's going to be an SpO2 greater than 94%. Or for circulatory, as we talked about, we adjusted this for the vast difference in ages of children, and so it's resolution of hypotension or shock. Essentially, we're bringing that patient up to the lowest blood pressures that they would be appropriate for their age. Or we're going to initiate our exit strategy. For respiratory, that's going to be persistent hypoxia despite placing an SGA or King tube, or taking the appropriate surgical or needle airway for that patient depending on their age. For circulation, that's going to be contacting OLMC and starting vasopressors. Let's talk about assessing the status of airway and breathing now, as there's some pediatric specific things that are different from adults. Our first question, just like for our adult patients, is going to be, are they in respiratory distress or are they in respiratory failure? We need to differentiate those things out. First, for respiratory distress, you can see in yellow that we add a few new things that are pediatric specific. Again, our respiratory distress patients are going to be those that have increased work of breathing, there's difficulty speaking in full sentences, or for those infants and young children or are crying and having difficulty. Also, accessory muscle use or retractions is an indicator of respiratory distress. And then for pediatrics, also nasal flaring or pursed lips can be an indicator. And then finally, you have an SpO2 less than 98% on room air, and then they pop up very nicely and quickly with just a little bit of oxygen up to normal values. All right, now we're going to look at a few less than 15-second videos of respiratory distress in pediatrics. I feel that watching these videos and visualizing what it actually looks like on a child is extremely helpful. The first one is going to be with retractions. So in this infant, you're going to see some substernal retractions as well as some subcostal retractions along the rib cage and some abdominal breathing. So here's that video. Now we're going to look at a video of an older child with retractions. Again, we're going to see some there, and you're going to actually hear the physician describing them in the emergency department.
Mom, Dad, you were telling me it's been how many days? 3 days, and that when did he really get short of breath and start working?
This morning.
Yeah, so you can actually see the intercostal retractions. You can see the abdominal breathing. He's working a little bit on his chest here, a little sucking in, super clavicular, super sternal anyway.
Now, this is another example of respiratory distress in an infant. This is grunting. And so what grunting actually is a partially closed glottis, and the child is essentially auto-peeping or trying to stent open the lungs, and that's what you're going to hear, this grunting sound. Now this is another example of respiratory distress with nasal flaring. What I want you to do is focus on the nostrils on this child. Now this is nasal flaring in a little bit older child. Again, just focus on the nostrils on this one. She's in the emergency department being treated for essentially a new onset asthma or respiratory distress type of picture.
What nasal flaring can look like. Was she here yesterday for wheezing too?
She got an appointment with her pediatric.
Let's move on to respiratory failure now. Obviously, this is going to be quite concerning to us. Highlighted in red are some pediatric specific things that we've added to the protocol to incorporate the full age range of children that we see. In the white is the same as your adult crashing patient protocol. First off, poor respiratory effort. That's going to be a whole lot of effort for not a lot of good, or gasping, which is essentially in infants a sign of respiratory failure, and you'll hear something to. Next is going to be unable to speak for your older children, or cry in infants and young children. Essentially a young child or an infant who you are seeing significant respiratory distress in, but they're silent. That should be a particularly concerning thing for respiratory failure for you. Next, loss of muscle tone. This is essentially a reference back to the pediatric assessment triangle that we talked about previously. Or for your older children, loss of control of posture as well. They're no longer able to tripod and sit up, and they're just slouching and slumped back. Next is altered mental status in your older children who you can actually assess. And then for infants and young children, the loss of interactivity, where they're no longer looking at you, following you, or their parent around the room. The next is going to be SpO2 less than 90% despite putting on oxygen. So this is the patient who you put a non-rebreather on and they only come into the mid-80s. That's again the by definition hypoxic respiratory failure. And finally, don't forget about utilizing your end-tidal CO2. You may find that they're hypoventilating, or over a period of time you may see steadily increasing end-tidal CO2 values, or hypopnea, or that speed bump ventilation. Again, those are similar things in pediatrics to your adults as far as end-tidal CO2 goes. Here's some examples, again, less than 15-second videos of some respiratory failure. First is going to be pediatric head bobbing. This is a sign of muscle fatigue. The patient's front muscles of their neck are pulling up their diaphragm and their chest wall while they're fatiguing out their extensor muscles of their neck, and you're going to see the head bob up and down. This is a particularly concerning sign for respiratory failure in infants. Next is going to be seesaw or paradoxical respirations. Essentially what you're going to see is during inhalation, the child's chest is sinking in due to so much effort, and then you're going to see the abdomen doing an opposite motion. And so you're going to see a seesaw back and forth of the chest and the abdomen. And this is a diaphragm that's tiring out, and they're just putting a ton of effort in the chest and sinking the chest down. So when inhalation happens, the chest goes in. When exhalation happens, the chest is actually going out. The opposite of what we normally see in normal respiratory breathing. Here's an example of seesaw breathing in older children. This is a child who is in respiratory failure from asthma. They're basically prepping to intubate this patient in this video. So here's respiratory stress and respiratory failure together again. That's going to be our sole goal in our initial assessment, is to determine are they in distress or failure. The next step that we should take is to determine what kind of respiratory pathology we're working with here. So we can divide this out into upper airway, mixed, or lower airway. And so for our upper airway, this is going to be typically either a croup or a foreign body type thing. And so also epiglottitis is included in this, but in the post-vaccination stage, epiglottitis is extraordinarily rare. And so we're generally going to be working with those top two if you see it. The middle category of mixed, this is your anaphylaxis or bronchiolitis. Essentially, you have something going on in either the nose or your glottic region and something in your lower airways going on all at the same time. And so that's why those are mixed. The lower airway type things that we're going to see are particularly asthma and pneumonia in our children. For respiratory distress, if you don't know where else to go, start with these initial interventions first. Position the child in the position of comfort. If they want to lay or sit in the chair or the bed, that's fine. If they're comfortable in the parent's arms, that's perfectly fine too. For those children that aren't already sitting up, sit them up and improve their respiratory mechanics there. If they're an immature child, such as a young infant, sit them up with the assistance of either your partner or the parents as well. Infants are obligate nose breathers. They're required to basically breathe through their nose up until about 6 months of age. So if you see they got a bunch of snot bubbles coming out, suction that out first. Open up their upper airways, and that may be all you need to do to relieve the respiratory distress. So don't forget about that for your young infants. And then also start applying the maximal oxygen you can to that patient. Maybe that's a nasal cannula, maybe that's a non-rebreather, or it may be blow-by. We understand that pediatric patients are not going to tolerate having a mask slapped on them as well as many of our adult patients. For your older children that fit on CPAP, consider that as an option as well. But obviously, for our smaller children, that mask is not going to fit. Next, let's move into the treating underlying causes a bit more. Our first one that we're going to look at is that first upper airway thing, and that's croup. Typically, this is going to be in your children 6 months to 3 years of age with a peak incidence at around 2 years. It's going to be your number one cause of acute stridor, particularly in the late fall to winter months. Symptoms are going to include the fever, that very characteristic barking cough, and then difficulty breathing and respiratory distress. And so the pathophysiology behind this, as you look on the diagram on the right, is infant airways are obviously much smaller than our adult airways. If we add about 1 millimeter of edema to that airway, you see that infant's significantly closes compared to that adult's. Also, by physics, when you narrow that airway down, you see a significant increase in resistance, so about 16 times for infants, compared to only about a 3 times increase in resistance from the adults. And so when you add resistance to that airway, you start hearing stridor. And so this is exactly why you see in your young children that they're much more prone to stridor from croup. So as we talked about, this is an inflammation of the trachea as well as the glottic opening, and it has a characteristic stridor and barking cough. So this is going to be a video that you'll see that shows these characteristic things. Now let's move on to the treatment for croup. First, keep the patient calm. If they get all agitated and start breathing faster and screaming and crying, that's not doing any good. So attempt to keep the patient calm. You don't want them worsening that swelling or having to breathe even faster through a partially constricted airway. If they have stridor at rest or on exertion, that's where our racemic epinephrine nebs are going to come in. Don't hesitate to start one of these if you recognize croup. Also, don't forget to give a dose of dexamethasone. This is a great treatment and will start beginning to diminish that inflammation, and is going to be one of their first things in the emergency department after racemic epinephrine if we don't give it out in the field. Be sure to notify when you do transport that patient that you did give a dose of dexamethasone, as that's an important thing for disposition from the emergency department. Now let's move on to our second cause of upper airway respiratory distress. And that's going to be a complete foreign airway body obstruction or choking. This is very common in children because we know that they put objects in their mouth and they're more prone to choking on food as well. So our first step is going to be BLS maneuvers. Younger children, that's going to be our back blows and chest thrusts, or the Heimlich maneuver in older children. Next, if we need to, we're going to start visualizing that airway and trying to retrieve any object or food that we can with McGill forceps. Next, we're going to move on as we need to attempt an intubation, and if we need to, force that object or food down the right main stem. That way we can ventilate on the left lungs. At any point we're starting to get into a significant airway crisis or a COCV, or can't oxygenate, can't ventilate situation, we're going to move on to advanced maneuvers at that point. The last part is epiglottitis here. Again, we discussed that's fairly rare after vaccination became a thing. And so at this one, do as minimal as possible. Don't start IVs if we don't have to. Don't agitate that child. Keep them calm in the mother or the parent's arms, and let's get them to the hospital where we can have the advanced airway maneuvers available to us there. Again, keep them calm, do as little as possible there. Next, let's move on to severe anaphylaxis. Very similar treatment to our adult patients. Again, we want to be aggressive if we recognize that a severe anaphylaxis situation is there. Pop them with IM epi as soon as possible. While we're setting up the drip, if we need a second dose, we can get them a second dose of IM epi, and we're going to start an epinephrine drip. Same mixing instructions as our adults in that case. Also, we're going to start nebulized medications to try and open up any wheezing that we can. And then after we've done all those things, then we can consider starting to give some diphenhydramine or giving them some steroids as well. The other mixed cause of respiratory distress is going to be bronchiolitis. You're going to hear Levi speak on this a little bit more in detail about what bronchiolitis is and how we're going to treat it. But essentially, start with the nose, especially in younger children. Start sectioning that out and then apply oxygen as you need to help supplement their O2 and give them a little bit extra support. Let's move on to wheezing and bronchospasm. Typically, this is going to be your asthmatics greater than 2 years of age. First, we'll start off with our standard ANA nebs times 3, that if we need to, we'll move on to our continuous nebs as well. Give the patient a dose of steroids, and then don't hesitate to give magnesium for your severe respiratory distress children. Just like adults, this can work wonders. I will caution you though that the magnesium concentration that we carry is different than the Brazil or the Pediatric. So unfortunately, you will need to do some math and calculations for your dose for this medication. For your bad asthmatics, don't hesitate to give an intramuscular dose of epinephrine, just like our adults. And then finally, if the child has been breathing and having significant respiratory distress for some time, we can generally assume that that patient is dry. So consider giving a normal saline bolus, especially if we're going to have to go on to advanced airway maneuvers with that child. Also, don't forget about oral dexamethasone. This doesn't require an IV, we don't have to stick a child, and generally oral dexamethasone is tolerated by children fairly well. We're actually going to be adding a study soon that's going to be looking at how often children get steroids out in the field for asthma, and if oral dexamethasone can help and get these children steroids earlier. Respiratory failure, we got this. Obviously, we've seen this slide a ton of times at this point because it is so important. Remember, put your NPAs and OPAs in, get a PEEP valve on. Children, just like adults, benefit from PEEP to stent open their lower airways. Get a good seal and a good jaw thrust. Elevate the head of the bed as we need to. Place that patient in ear to sternal notch. We'll talk about some caveats, especially in smaller children, in a second on that. Get a second oxygen source on that patient. And then finally, verify good end-tidal CO2 with every breath. Just because we say max BVM doesn't mean to bag at fast rates and big tidal volumes for our pediatric patients. First, we're going to cover ear to sternal notch though. For pediatric patients, particularly less than 3 years of age, their occiputs are huge. And so they're going to put them out of ear to sternal notch even more. And so for less than 3-year-olds, we really should be considering a towel roll behind the shoulders if we can. Then we may need to buttress up the head with a little bit more to get them into full ear to sternal notch alignment. Again, we have to correct for that big head by the shoulder roll as we need to. Second part of this is get 20 breaths per minute. We're very amped when we take care of pediatric patients, and quite often we'll be bagging at a much higher rate than 20. So again, diligent and deliberately look at your rates and verify that you're giving the appropriate rate for a child. Also, our BVMs for children are typically 450 to 500 mLs. That's way too much for a pediatric patient. It's quite frankly about the size of an adult tidal volume. So we want to ventilate just to chest rise. We don't want to inflate the gut and contribute to even more respiratory distress and failure for that patient when we're bagging them. Also, we don't want to induce any vomiting if we can help it. So if we're bagging that patient and despite our max BVM and our best technique, that patient remains persistent hypoxic, just like our adult patients, we'll place a quick king. If we get into a COCV or can't oxygenate, can't ventilate situation, there are some differences for children here. For adult airways, the airway is structured that the glottic opening or at the vocal cords is the narrowest region. After that, it's shaped like a cylinder through the trachea and is generally the same size. For children, however, their airways are structured like a cone or a funnel. So the cricoid ring is the narrowest part for children. This makes it particularly difficult to pass a tube. Also, the cartilage of the pediatric airway is underdeveloped, making the airway flimsy and floppy, making it not have enough structure to place a crike. Typically in the pediatric emergency departments, anesthesia world, or the ICU, crikes won't be attempted until at least age 8 or greater, and that way they are usually placing a tracheostomy in those cases. Obviously, we're not going to place a trach though. So for your less than 36 kilogram patient or a Broslow tape, green or smaller, essentially if they're on the Broslow tape, we're going to perform transtracheal ventilation or TTV. This is where we're going to place a 16 or an 18 gauge needle in through the cricoid thyroid membrane, advance the cannula down, attach a 3.0 adapter to the top from an ET tube, and then we're going to start BVMing that patient, allowing for good chest rise and fall. Don't get too tripped up with this right now. We are going to be covering this under the procedural part of the protocols moving forward. Just like our adults, pediatrics greater than 36 kilograms are about 11 to 12 years or older. Then we're going to be able to move on to a surgical crike like normal. So again, less than 36 kilograms, TTV, greater than 36 kilograms, surgical crike. Here's the algorithm that we're familiar with. This one is for the less than 36 kilogram patient, however. First, we're going to announce a COC via emergency to the entire room. Then we're going to attempt our world's best max BVM ventilation. If we get end-tidal CO2 back, that's great. However, if we do not, we've essentially proven that max BVM is no longer an option or effective, and we need to move on rapidly and deliberately to next steps. This is going to be our simultaneous setup at this point. Set up for a king, set up for TTV. We're going to attempt to place a king rapidly, and if we get end-tidal CO2 back, that's great. However, if we get no end-tidal CO2, we're going to perform our TTV procedure at that point. This may or may not give you end-tidal CO2 when you perform a TTV, as that needle is fairly narrow and may be difficult. It's worthwhile trying, but just understand you may not get end-tidal CO2 back with the TTV procedure. For our patients that are greater than 36 kilograms, are around 11 to 12 years of age or older, it's going to be our standard adult flow here. First, we'll announce the COCV, attempt max BVM ventilation, and if we do not get end-tidal CO2 back, we'll do our simultaneous setup of a king and a crike. We'll attempt to place our king, and if we get good end-tidal CO2 back, that's great. However, if we do not get any end-tidal CO2 back, we're going to rapidly perform our crike. After the crike, we're going to secure our airway and monitor CO2 after that point. I know we talked about a bunch of different things already. However, if you've met your respiratory goals right off the bat, you're greater than 94%, there's no respiratory distress or failure, maybe it's just a circulation issue. The child's dehydrated and just needs some fluids. If you don't need to deal with a bunch of respiratory stuff and you met your goal, move on, attack the other things, and then get the patient transported appropriately after. But if we've done some things for the respiratory status, our goals are greater than 94%, or our exit strategy. For persistent hypoxia, we're going to drop a supraglottic airway or a king as appropriate, or we're going to take our steps of a crike or TTV as we need it. Next, we're going to assess our circulatory status. So if the patient is hypotensive and shows sign of shock, we're going to begin our interventions. As far as signs of shock, the ones in white are the same as our adults. I did highlight one in yellow, which is ped specific. So for pediatrics, as we may know, they may become tachycardic first and be progressively more tachycardic over time, and then hypotension may be a late sign. Additionally, we may see signs of shock such as pale, cool, diaphoretic, or mottled skin, or we may assess it with a poor cap refill, thready pulses, or finally, you may see a decreased mental status. Here's your specific numbers for determining hypotension for pediatric patients. For the fresh ones less than 1 month old, blood pressure is going to be less than 60 to determine hypotension. For those 1 to 12 months or 1 year of age, it's going to be less than 70. And once we get into the 1 year to 10-year age range, it's going to be 7 plus 2 times the age of the child. For greater than 10 years old, we finally get back into adult ranges, and the blood pressure of less than 90 systolic would determine hypotension. Keep in mind that these parameters are important, and don't assume that a low blood pressure reading is appropriate for that child without at least doing the calculation and checking the numbers. Our next question should be, is this shock due to a dysrhythmia? For children, this is going to be extremely rare that a dysrhythmia is causing it. For unstable bradycardia, your number one cause is going to be respiratory in nature first. For an unstable tachycardia, just like your adults, it's rarely the cause of shock, and you should search for underlying causes first. SVT in kids is generally well tolerated and should not present with hypotension most often. As far as an unstable tachycardia goes, for infants, it's going to be defined as greater than 200 beats per minute, or for older children, greater than 180 beats per minute. Both of these require, though, to be an unstable tachycardia, hypotension, and or poor perfusion. If we do indeed have an unstable tachycardia by those parameters, that would be where we would go into a synchronized cardioversion. Below you see the doses of your shocks. However, you should also refer to your Pediatric or Broslow as you need it, because they will calculate those out for you. As far as unstable bradycardia goes, it's going to be a heart rate less than 60 beats per minute or relative bradycardia. So what does that mean for relative bradycardia? For that, that's going to be basically a heart rate which is much lower than expected for that age range of patient. And just like an unstable tachycardia, you still have to have your hypotension or poor perfusion to be that unstable category. Your number 1, 2, and 3 causes for an unstable bradycardia are going to be oxygenation and ventilation. So this is probably the most important thing first, is that hypoxia is going to drive bradycardia first. So we need to correct that rapidly, and then we're going to assess if the heart rate's still low and can correct that as we need to. Our question for an unstable bradycardia is going to be, is the heart rate less than or equal to 60 beats per minute? If the answer is yes, this is essentially a peri-arrest territory, and some children will progress onto full cardiopulmonary arrest. So if the answer is yes, we're going to begin CPR per PALS guidelines. Once we started CPR, we're going to administer a dose of epinephrine. If the heart rate is greater than 60 beats per minute, our first move is going to be going to epinephrine IV IO. As you note below, the mg per kg is the same for cardiac arrest. However, the total dose is much smaller than cardiac arrest. It's going to be 0.1 milligrams as your top dose, or about 100 micrograms. PALS also allows for atropine if there's an AV block or increased vagal tone. However, that's going to be a secondary thing. Epinephrine is going to be your go-to for unstable bradycardia if it's greater than 60 beats per minute. So if we have poor perfusion and persistent bradycardia despite all those initial measures, then we're going to consider pacing for children. This is obviously different from your adult patients, where we're going to go to pacing first. We need to do those initial measures and then move on to pacing if they don't respond. So for your current, it's going to remain at 30 milliamps just like your adults. Additionally, capture thresholds are going to be similar to your adults as well. Your rate is where it's going to be different. Obviously, kids rely on different heart rates depending on their age. So for 0 to 36 months, our pacing is going to be at 120 paces per minute. 36 to 12, it's going to be 100 paces per minute, and greater than 12, it's going to be similar to our adults at 70. To establish capture, we're going to rapidly titrate to a max of 140 milliamps as we need to establish capture. Keep in mind also that our pacing pad placement is going to be similar to our adults as well. Obviously, dysrhythmia is going to be fairly rare. The vast majority of hypotensive children will fall into the general medical category of shock. Number 1 cause is going to be fluid loss and the tank being low. This is things like vomiting, diarrhea, poor oral intake adding up to a dehydration type picture. Also, don't forget about pipe problems such as sepsis. Sepsis is especially common in younger peds patients. Finally, don't forget about anaphylaxis and other causes as well. So if fluid loss and sepsis are our number 1 and 2 things on our differential, we're certainly going to start off with some fluids then. Children rapidly and readily respond to fluids in general. We're going to start with a 20 ml per kilogram bolus, just like our adults. If that's not enough, we're going to reassess and repeat up to 2 liters. Keep in mind that pediatric dosing is generally ml per kilogram, and so my best recommendation would be about a max of 60 mLs per kilogram before considering moving on to advanced measures. Also, remember that fluid responsiveness is variable by condition. So if you see a child who continues to decline despite fluids, we may need to move on to advanced measures more rapidly. So if the child remains hypotensive despite adequate bolusing, then you're going to contact OLPG for norepinephrine dosing and starting. Remember, for anaphylaxis, you don't need to call, and we're going to start early epi for that. IV access is obviously notoriously difficult in kids. They certainly have smaller, more friable vessels, and they're more difficult to find, especially when the child is in shock. We also lack experience compared to our adults. So for the critically ill child, do a couple attempts at an IV and then move rapidly on to IO access. Remember, IOs started first in the pediatric population, so don't hesitate to start an IO as you need it. It's difficult, especially when we're trying to put something under pressure, to give an accurate bolus in kids. And so consider using a syringe bolus. For those that are familiar with a push-pull setup, this is fairly similar. What we're going to do is we're going to pull the fluids out of the bag and then administer them via syringe. If we need to repeat with more syringes, we can do similar. This is going to be usually your 60 cc luer lock syringe, where we can essentially give the fluids accurately and under pressure at the same time. This is here just to remind us about the glucose one more time. So if you're working on a crashing or septic neonate, particularly less than 1 to 2 months of age, remember that hypoglycemia is common in this age range as well. So remember to get a glucose and administer D10 as appropriate. Some children are just going to have a pure respiratory issue. If you get down to your circulatory status and we've assessed and they have an appropriate blood pressure and perfusion, then we can move rapidly through our circulatory goal. However, if we've initiated treatment, our goals are going to be either the resolution of hypotension or shock, or we've started our exit strategy of the initiation of vasopressors. At this point, once we've met our respiratory and circulatory goals, it's okay to initiate movement and extricate the patient, not necessarily transport just yet. Once we're in the truck, we're going to titrate interventions to maximize effect, put that bow on top, quickly wrap things up, and get going. I want to briefly touch on intubation and drug-assisted airways. Just like our adults, we have goals to meet prior to initiating these things. Similar to adults, our SpO2 needs to be greater than or equal to 94% before starting these things. Shock index is generally not a thing for kids, just generally because their heart rate is higher than adults and it throws off your formula. So don't use shock index in kids. You're just targeting their age-appropriate systolic blood pressure. Again, just because you've reached the minimum blood pressure for that child, maybe you need to consider bringing that up just a little bit more to make a safe drug-assisted intubation in some cases. I want to go over a few tips and differences when we're intubating children. First, the greatest changes are in that 0 to 24 month range. Children become about adultish by about 8 to 10. So in your less than 2-year-olds, this is going to be by research base, the lowest first pass success. So I really emphasize using max BVM and your supraglottics in this range, because this is where we're going to have the most difficulty establishing an airway. So again, if we can minimize intubation and drug-assisted airways in this range and get by with less, that's absolutely appropriate. Also, children have less functional residual capacity, or FRC. They also have a higher metabolic demand. Both of these things essentially combine into a shorter time to desaturation in our shorter intubation attempts. Also, especially in the younger kids, their larynx is going to be higher and more interior. So we are critically needing to put the patient into ear to sternal notch and not hyperflex the neck. If we hyperflex the neck, that just makes them even more interior. The epiglottis also lies just at the base of the tongue. So this is even more important to use epiglottoscopy and slow progression down so we don't overshoot the epiglottis and the cords along the way. Children also have floppier epiglottises than adults, and so we want to use a pediatric bougie. This is appropriate for a 4 to a 6/0 tube for this case. That will enable us to bypass that floppy bougie and not get hung up by using a tube alone. Finally, children have shorter tracheas as well. So be very cognizant of your depth and refer to a reference guide as you can to ensure that we don't right main some of these kids, as that's especially common. All right, if we've had to initiate airways, once we've met our goals, at this point, we're okay to transport. The last thing I want to talk about is some special circumstances, particularly congenital heart diseases, as well as some chronic lung diseases and metabolic disorders. It's very important to determine the child's baseline status from their parent or caregiver who knows them quite well usually. For some congenital heart diseases, such as hypoplastic left heart, where they have multiple complicated cardiac surgeries, such as the one you see on the right there, this is a situation where they may never, and it's actually inappropriate to raise their SpO2 levels to a normal range. Also, for some chronic lung diseases, the child may live hypoxic, and then from some metabolic disorders, they may always have a baseline low blood pressure. So again, discuss with the parent what is normal for that child. So that's crashing patient medical in a nutshell. Again, review this protocol, could be familiar with it, and be able to rapidly deploy it from memory.